my great pleasure to introduce our speakers today. So it's going to be two speakers for a single topic round. The topic is very exciting. It's ambulatory hemodynamic monitoring ACHD heart failure, and will be delivered by Dr. Curt, who is the director of the Columbus, Ohio ACHD program. In the Ohio State, Curt doesn't need a presentation, but she's the former president of the International Society of ACHD and is the chair of the ACHD Subspecialty Exam Committee, and has a lot of have done a lot of work in education in cardiac heart disease, and is also the chair of the ACHD Association Program Accreditation Committee, and is joined here today by Dr. Myanmar. He's an assistant professor in internal medicine and pediatrics, and he is an ACHD that has just he's in really happy with what I do, and I need more people like Liam in the field. So, really, thank you very much for us, and I'm really looking forward to your talk, and the floor is yours.
Yeah, thank you, and thanks for the opportunity. Get the price of one today, so hopefully for Marshall and when he gets into the next, because we're leading into what we do here. My disclosures. I'm going to start a little bit with the congenital heart population, just to lay the groundwork. As we know, children with congenital heart two-thirds margin, and we know the data. And if you look at the data from Montreal, 39,000, and you switch this to the U.S. number, the United States, so it's a big number. And by the change in the congenital heart, which will be a theme today, that severe congenital heart mutations are increasing in rapid numbers within congenital heart disease. If you look at the mean age from 1985 to 2010, you see this increase in the median age, and so those with severe congenital heart disease are clearly centered in adult congenital heart disease. This is really and should be considered success. We have tremendous success in working with survival of those with severe forms of congenital heart disease. But then I also say we success have really great responsibilities and challenges for us. Our systems are challenging, have a number of long-term complications. As you know, arrhythmias, aspiration at the top of the valvular, cardiac complications, residual shunt, and today we're going to be talking about heart failure. Admissions for adult heart conditions are rapidly increasing throughout centers. A number of studies demonstrate this. When you look at the around these hospitalizations, it is heavily weighted on heart failure. The mortality from the study from the lens, number of causes of death is high. And this large study in our colleagues in the sections following death here, the number one cause of death is heart failure. We'll come back to this slide. And in that study, is responsible for about 42% of deaths in ECG patients, and if you look at the incidence of cause of death over time, you can see all the curves at the bottom, sudden cardiac death, acute MI, or interventions, they usually increase as patients age and look at heart failure. So not only is it a large percentage, but it accelerates with age as the patient population ages. In the study, they looked at national registry and the evidence of first heart failure patients will develop heart failure. And in this study, they developed heart failure about 5 years acquired heart disease. So we're pushing, from these in our population, 20 to 25 years, beginning to have heart failure, so heart failure a lifetime for many. And this population is not the corner with an editorial piece with this figure for the paper listed from the UK, and he shows that the prevalence of congenital heart disease really is not expected to change over time. The prevalence of an adult congenital patient is going to continue to increase over many years, those less than 60 and those over 60. And Seattle did the same type of analysis in a slightly different way, but they also looked at the projected growth of our adult congenital population over the next several decades, and looked at ACHD cases, which are here, and then looked at prevalence, which is here. And you can see, and they quote, that we don't expect the prevalence of adult congenital heart disease really to level out until 2050 to 2060. So the population is going to continue to rise. I put this slide in because I gave a lecture in 2013, so a decade ago. I had a slide on all the different major issues with adult congenital patients and with the population, with the specialty taking care of those patients, how it affects all these various institutions and the patients. And I think if we move forward now a decade later, and this is before, for us in the U.S., before we had a board specialization, we had standardized training, so again, a decade ago. But if we move forward, although many of these are still important, I would say our number one tidal wave tsunami, so to speak, is heart failure in the population. And you can see how, again, it's going to affect many, many institutions, the patients, and then certainly is stretching our ACHD programs in terms of the ability to take care of these patients. So for this beginning part, there are more adults than children with congenital heart disease. The ACHD population and prevalence will continue to rise for the next several decades. The majority of those complex diseases are now adults. And heart failure is the most common cause for morbidity and the most common cause for mortality in the population. So which patients with congenital heart disease are the highest risk to develop heart failure? Well, if I go back to this study from the UK and sort of highlight that top line and look across the board, it's those with complex congenital heart disease, those with Fontan, single ventricle Fontan, those with systemic right ventricles. Look how high those percentages are in those populations, with overall being 42.5%. If you go back to the study from Sweden, when they looked at the highest risk, it was those that developed heart failure, had complex congenital heart disease. The conotruncal defects were the highest risk population. When you look at the types of patients who develop heart failure and some of their outcomes, the study from Toronto, they looked at their ACHD heart failure clinic, 126 patients, and looked at the types of patients they were seeing and then the outcomes of those. They divided them up into three anatomic categories: single ventricle, 2V RV, so systemic right ventricles or subaortic right ventricles, and then 2V LV patients. And they looked at the primary outcome of death, transplant, and the need for ventricular assist devices as their primary outcome. 38 patients over this follow period developed that primary outcome. And we looked at the anatomic substrates, the 2V RV, the subaortic RV patients, systemic RV patients that were independently associated with death, transplant, and need for VAD. And graphically, you see here the green line is showing the freedom from this primary outcome. So the 2V RV patients significantly separate themselves from the others in this particular study. When the Mayo Clinic looked at their patients who developed heart failure over time, over 5,000 patients, again, it was the Fontan patients, those with congenitally corrected transposition, and those with transposition, detransposition, the atrial switch were high percentage of those patients. And when they looked at the Kaplan-Meier curves for the incidence of advanced heart failure, it was severe congenital heart disease. But again, looking at the anatomic substrates, the single ventricle patient Fontan and the systemic RV patients were the highest risk to develop heart failure. So we're starting to see a pattern in our patient population. This patient population of subaortic RV, sometimes called systemic RV, 2V RV, I'll interchange those probably throughout the rest of my talk. That population, and then the single ventricle Fontan patients, which you know have many different forms of congenital heart disease that all lead to single ventricle Fontan. And so these appear to be some of our highest risk populations for heart failure, and then for potentially poor prognosis related to heart failure. So if we think about the DTGA atrial switch patients listed here, and this was a large study done by Craig Broberg and colleagues, center study over 1,000 patients with DTGA atrial switch. Their follow-up was 9 years, and 91 met the factors. You look at the various risk factors that are listed. Heart failure admission was a significant risk factor for meeting their endpoint. So once you had a heart failure admission, in a much greater likelihood of having that primary endpoint. The group from Montreal took this a step further, I would say, in terms of those who had heart failure, and they looked at 140 adults with DTGA and the atrial switch procedure, and 33 of them underwent a heart catheterization for heart failure or exercise intolerance. And from those patients, 75% of them had evidence of pulmonary hypertension, and again, probably younger age than we might expect, 34 years of age in this study. And when you look at the type of pulmonary hypertension, the majority of them had isolated post-capillary pH listed here. They had elevated wedge pressures, they had lower pulmonary vascular resistance, so isolated post-capillary pH. And when you looked at freedom from death, those patients who had pH had a much greater mortality rate with a hazard ratio of 9.4 compared to those who didn't. So once you develop pulmonary hypertension, the risk of poor prognosis and death was much greater in this study. The group from Toronto also looked at pulmonary hypertension in subaortic right ventricle patients. So this also included CCTGA as well as the DTGA atrial switch patients. Looked at 141 patients, 191 heart catheterizations, and they found that only BNP, but not age at catheterization and not the echo estimate of LV systolic pressure or trying to estimate pulmonary pressure predicted the association with the presence of pH. So an important finding as we're trying to decide which of our patients by risk factors may have pulmonary hypertension. They found a mix of both isolated post-capillary, just like the previous study, but also combined pre- and post-capillary pH. And also when they looked at their endpoints, which were death, VAD, and transplant, those that had pH and had an elevated BNP had a significantly reduced mortality or meeting the primary endpoint. So again, developing pulmonary hypertension is a poor prognostic feature. And they concluded, which I think is important for our discussion today, that pH is prevalent in the patients even when asymptomatic. A very important point when you look at their study in detail, they found that depending on the age, 20 to 40% of those who developed pH were asymptomatic and had normal BNPs. Again, important, we're trying to risk stratify who should undergo heart cath and who is concerned for pH. And they said it's difficult to identify pH by echo for most of them. And once they develop pH, it has potential for adverse outcomes. It affects transplant options. And so we need to consider more assessment, hemodynamic assessment of the patient population. So this group, this 2B RV group or systemic RV patients are on a trajectory towards heart failure. The majority of them are. And when we think about the development of pH, are they developing pH here? Well, this previous study would say yes. I mean, as much as high as 20 to 40% of them may already develop pH with very mild symptoms, asymptomatic and mild symptoms. So again, we may miss that opportunity. Certainly, when they develop heart failure symptoms, the risk is much greater. And then when they start to deteriorate, the risk is higher. But the percentage is based upon the prior study from Toronto looking at the development of pH. And you can see where it happens early and continues to progress over time. What about the single ventricle patient, Fontan patient? What about their risk? And again, these patients are similar in some ways to the DTA atrial patients. Nice paper, Dr. Chaudhary and colleagues looked at the similarities, but also the differences. We know our single ventricle Fontan patients are different. They have lymphatic congestion. They have Fontan-associated liver disease. They have potential for protein-losing enteropathy. So even though there's similarities, there's some very unique features. And also, they're very unique in terms of the Fontan failure. Not all Fontan failure is systemic ventricular failure. Wendy Book and their colleagues at Emory a decade ago described these phenotypes that we still talk about today. And so Fontan failure is not one type of physiology. And so one fix probably won't help all patients. We need to obviously think about that in Fontan failure patients. I'll come back to this slide in just a little bit. So we have many challenges in adult congenital heart disease, heart failure, some that are specific to our populations, such as Fontan-associated liver disease. Some are common to heart failure, such as pulmonary hypertension. There may be unique features in this patient population in terms of detecting hypertension, or how do we know when they develop pulmonary hypertension, maybe a little bit higher in the population. and also the lack of evidence of medical therapy. So what about medical therapy? We have options for our patients. So we know in our heart disease, there's well-described, very clear guidelines that continue to update medical therapy, show promise, and show our patient population to show a little algorithmic outline of that. And we know that these therapies help those with heart disease, with their raw mortality, their cardiovascular mortality, their hospitalizations. But can we apply this medical therapy to our ACHD patients? This was a nice paper from Jeremy Moore and colleagues, just looking at the different basic anatomic substrates that can develop heart failure along with arrhythmias. And if we look at those who have a systemic left ventricle and have systolic dysfunction, the Mayo Clinic looked at this particular question with 550 patients, and those who had left ventricular systolic dysfunction with ACHD, and found that medical therapy and CRP did work in the population. It improved the ejection fraction for the patients. So we can apply these therapies to our ACHD patients who have a systemic left ventricle and heart failure. About systemic RV patients. With a systematic review that was published along with their ACCHA guidelines that looked at this particular question for a systemic ventricle with 6 studies, 187 patients. It basically concluded that at that time that with ACEs, ARBs, beta blockers, aldosterone antagonists, there's no data to support the time that these therapies are beneficial to the patients. And in fact, in our guidelines, we wrote a conclusion statement that said, we cannot recommend these therapies at this time. But since the publication of guidelines, there's been several studies looking at RNA and trust therapy for our patients. Here, and these three, I think, are worth highlighting briefly because these all three respond to systemic RNA base, and they all had similar findings that it did improve heart function, whether we're looking at fractional area change or global strain, looking at 6-minute walk distance, quality of life, BNP, they all showed some improvement with the others. Other studies in the past, the traditional directed therapy has not shown that. And here's a graphic from Dr. Fusto's study Italy showing that BNP does decrease, it seems to level out after a year, shows that the 3D ejection fraction by Aglo improved from mid-30s to low 40s, and then showing the 6-minute walk distance also improved for the patients. Well, what about for single ventricle patients and medical therapy? Well, this is about all we could find. There's not a lot of studies, and I'll just say, in conclusion related to this, that there are really no studies demonstrate significant improvement in Fontan failure, with medical therapy. And part of the reason is that we have these different phenotypes. So many studies have been performed even with PAH therapy. Fontan patients really don't look at their physiology. Most of those studies don't include heart catheterizations and physiology beforehand. And so maybe in this first group, goal-directed medical therapy might work since it's related to systemic systolic dysfunction. What about in this second phenotype where it's diastolic dysfunction? So maybe our medical therapies may work if it's directed towards that phenotype. And this third type where the hemodynamics are fairly normal, what about their PVR is elevated? We can treat that. And then this last one that's really related to lymphatic abnormalities, we have lymphatic interventions and pH therapy and therapies for PLE. So I think there needs to be a much more directed approach if we're going to perform studies looking at Fontan failure. So what do we do if heart failure progresses despite our medical therapy and CRT? Well, we know that most of our complex patients, the data suggests our heart failure therapies and interventions are temporizing at best. The majority will require advanced therapies, VAD, or heart transplant over time. Therefore, really our focus should be on improving quality of life, and then timing for advanced therapies becomes really critical as we sort of looked at the development of pH and should focus our area of research and care in this direction. And then some of the prognostic risk factors are the same as those with acquired heart disease, but many are different and they're not clear, they're not traditional, and there are less accurate means to follow patients than those with acquired heart disease where the anatomy is normal and we can get information maybe based upon echo. And so I go to this study or this review paper by David Crossland and colleagues, where they looked at advanced therapies and end-of-life care. But in this table, I found important where they talk about the red flags that should prompt evaluation to the heart failure, the ACHD heart failure team and the heart failure teams. And some of these are traditional, such as heart failure admissions, atrial arrhythmias, elevated BNP and biomarkers, but some are very unique to our population, such as the 2BRV patients developing pulmonary hypertension, Fontan patients developing worsening fall or worsening PLE. So I'll end my portion just with a little bit of provocative statements, I think, as we lead into Dr. Marshall's talk. So what if we had a way that we could follow hemodynamics in real time in an ambulatory setting and therefore respond with medical therapies to improve their quality of life and avoid hospitalizations and find the earliest possible moment in the development of PH as one consideration to then consider advanced therapies and avoid missing that window for transplant listing. And what if we had a way to lower Fontan pressures while maintaining cardiac output in real time in an ambulatory setting to potentially avoid or delay Fontan-associated complications, and we could trial phenotype-specific medical therapy, so directed at the phenotype without, I'll say, artificially derived cath lab-based invasive measurements. What if we had that? So I'll move over and let Dr. Marshall take the second half.
Thank you. It's an absolute pleasure to present today. I'd like to thank the admins of the ACHD program in Toronto for giving me the opportunity. So our outline today, we're going to review the evidence and guideline recommendations for implanted hemodynamic monitoring and heart failure in general. We're going to review the published literature on implanted monitoring in ACHD patients and describe our institutional experience with implanted hemodynamic monitoring in ACHD patients using some case examples, some recent data that's yet unpublished, and talk about some logistics and future directions. I have no financial disclosures, and we have not received any input from any monitoring company in putting this talk together. So before I go into a lot of detail, I want to give you a brief review of the development of implanted monitors for heart failure and how what's now the CardioMEMS device came to be. There's a lot of publications about this. I want to try and summarize some of the seminal papers. So the first description of an implanted pressure monitor was in 1996. And this device was in the right ventricle, and it looked like a pacemaker, and has a lead in the right ventricle in the pulmonary artery. And they showed that the pressure is correlated with the Swan-Ganz catheter measurements in the first study. And then there was a larger feasibility study in 2001. Later versions had just the right ventricular lead. And using this monitor, there were two multi-center, single-blind, randomized trials, COMPASS HF and REDUCE HF. Without getting into the specific details, neither met their endpoint for reduction in hospitalizations. And then REDUCE HF was stopped early due to late issues with lead dysfunction from the devices in the COMPASS trial. So next came the CHAMPION trial of the CardioMEMS device, and then followed later by GUIDE HF. So for those who are not familiar with the monitor, here is in panel A, the CardioMEMS monitor, and it's placed in the pulmonary artery in the cath lab. And in this example, it's in the pulmonary artery of a patient with Fontan circulation, foreshadowing some later content. And so the monitor is then calibrated to the patient's PA pressure by catheter. In panel B, you can see the patient lays on this pillow and sends transmissions for their pulmonary pressures to the website, which ends up looking like this on the website. This is not a patient with Fontan circulation. But this audience knows that PA pressure measured by the CardioMEMS is the same as the Fontan pressure in the absence of any pathway stenosis. So back to the trials for CardioMEMS approval. So both studies, CHAMPION and GUIDE HF, had a control group that had the monitor, but the treating clinicians were blinded to the pressures. CHAMPION had 550 patients with NYHA class 3 heart failure and prior hospitalizations, and GUIDE heart failure had more patients, but was more liberal with class 2 heart failure and patients with elevated BNP, but no prior hospitalization. CHAMPION showed a significant reduction in heart failure hospitalization, as you can see from the graph on the left. And then guide heart failure did not have a significant difference in heart failure hospitalizations or urgent heart failure visits. However, there was a somewhat controversial sub-analysis, including only data that was pre-COVID, which was significant. So the CHAMPION trial led to the initial FDA approval for NYHA Class 3 heart failure, and the pre-COVID analysis allowed expansion into use of patients with NYHA Class 2 heart failure and elevated BNP, but no prior heart failure hospitalizations. So for completeness sake, there are trials for left atrial pressure monitoring devices, which are ongoing under evaluation. As you can see here, the use of implanted hemodynamic monitoring is a key recommendation in the adult heart failure guidelines from the AHA and the ACC to be used to be considered after guideline-directed medical therapy is optimized. And the EST guidelines, there's the caveat of using it only in patients with LV dysfunction. So when referring to implanted hemodynamic monitoring or implanted monitors in this talk, it can be assumed from now on to be the CardioMEMS device unless otherwise stated. And so while not part of the most recent Canadian heart failure guidelines, CardioMEMS was approved for use in 2017, and the first device was placed actually in Toronto. So those are the initial trials, and there are some insights we can gain which are important when applying the data to clinical practice. So we can see here that higher implanted monitor pressures correlate with more heart failure events on the graph on the left. And on the right, you can see that patients with higher pressures have worse survival. So both of these seem to be intuitive. Second, in patients in the treatment group in these trials with a reduction in PA, estimated pressures on baseline in the first 6 months had lower mortality as seen on the left. Those who had increased PA ratios after replacement had higher mortality on the right. And in multiple studies, a change of 3 to 5 millimeters of mercury in PA pressure is associated with clinical benefit. In addition, multiple trials have shown that the increase in pulmonary pressure before a heart failure hospitalization events in 3 to 4 weeks before the patient ends up hospitalized. And patient adherence is to be important. In the CHAMPION trial, with an average of 333 days of follow-up, most patients will send physicians almost daily after 6 months. Compare that to a small real-world survey with around 3 times the amount of follow-up. And the patient reported compliance with daily pressure monitor readings was 89%. It was actually 74%, with a wide range is down to 19%. So real life patient adherence of lead transmitting is just not as good as the trials. And there's actually not a lot of data on patient adherence and the utility, but one study did show of 70 patients a correlation with more days spent hospitalized for heart failure if there were a longer duration between transitions or fewer transitions. Finally, before online monitors facts, what is the prime time they're used for monitoring this population? First, as you can see, there's some evidence that identified who benefit from that earlier participated in therapy. In green, that's benefit from bad speed based on implanted pressure monitors. In red, it is helpful to read heart failure hospitalizations. Under the right, you can see results of a multi-center trial of 100 patients with implanted monitors that most had ischemic cardiomyopathy, which are reduction in heart failure hospitalizations with higher ischemic tests in patients with pressures of less than 1. So with that background, what is published on implanted monitor use in ACHD patients? The first report on implanted hemodynamic monitor based on 2 patients with spontaneous circulation occurred in 2015 at Ohio State and Nationwide Children's. And importantly, Dr. Bradley, Dr. Berman, and Dr. Daniels showed that implanted monitor monitors were feasible, and that the pressure waveform correlated with the PA catheter waveform in non-pulsatile spontaneous pulmonary circulation. So given the prospective implanted monitor spontaneous feasibility works, And this 6 patients were treated similar to the control in the Champion trial. Their pressures were monitored, and clinical changes, treatment changes were based on the patient's clinical status. So this showed that higher PA pressures were significantly associated with these heart failure composite mediated events, and then absolute pressure of more than 4 millimeters of mercury, an increase in more than 4 millimeters of mercury were predicted of heart failure mediated events. And a cool exercise bike study of 4 patients, they showed that the PA pressures increased with exercise, more so in the patients who had systemic right ventricles. Circulation. This paper, also from Ohio State Nationwide Children's, described procedural considerations of minor replacement in complex congenital heart disease, including 8 patients with 5-10 circulation and 6 retransposition after mustard. And then the published case of monitor use in patients with congenital heart disease cited Ohio State and Nationwide Children's. And 9 total patients with congenital heart disease and implanted monitors from published conference abstracts. And finally, there are 2 reported but not published cases of monitors in congenital heart disease. And in this review, Dr. Morales from Cincinnati discusses a program using implanted monitors in use with content circulation and remote valve placement. As far as I can tell, this experience itself is not published. Finally, the ACHD Network Pediatric Congenital Heart Failure Registry patients with claims. Most recently, there were 24 patients involved. As you can see on the right, they have an infographic for patients and families to help understand the device. And this includes both children and adults with congenital heart disease, but also children with other causes of heart failure. So this really all there is on implanted monitor use in congenital heart disease, with 28 patients published or reported on social media. So this might include 4 patients in the ACHD registry. It also includes, as I said, just other causes of congenital pediatric heart failure. After a lot of experience, I'll have state insurance. We'll talk about that experience next. So between 2015 and 2023, we've done 41 monitors in ACHD patients. There were 19 population, almost split evenly between LV and systemic RV patients with diagnoses you can see on the top of the red. In the 2 ventricle population, we had 12 patients, most of them with systemic ventricles, 2 with CTG and 17 with transposition radial switch. And this brings 1 patient with a group at ASD, USD, and hypoplastic heart beat who had bidirectional circulation. This has been used for a lot of cases. Try to increase heart failure hospitalizations. This is a 45-year-old with a right ventricle after Fontan, who has ventricular dysfunction and had other contraindications for transplant. She had 3 heart failure hospitalizations, as you can see on the triangles. So she had the nerve-based and this you can see pressure over time, and she had 1 heart failure hospitalization just before 2022. Despite the worsening of her disease. And throughout 2022, we were able to successfully keep her out of the hospital. This was in part due to daily pressure readings and many chart messages and phone calls to titrate diuretics based on the monitoring pressures as well as weights and symptoms and renal function. The next is to show how we can be more emissions with daily. This patient with and daily and multiple hospitalizations. As you can see from the yellow dots on the axis right here, he has got chronic kidney disease, pancreatic close 2, and associated with edema and PA pressure. Two dots, his pressures were going up. And he was treated IV diuretics as an outpatient. Unfortunately, it was too late, and he was admitted for heart failure once again. After the diuretics, his renal function worsened somewhat. He still appears edemic, and his monitor pressures low. So they're able to reduce weight before continuing with fluid level. And then they discharged the exam and independent monitor pressure is usually. So it kind of be an augmentation of the physical exam fluid status. Here you need some examples of with implanted brain without repeat catheterization. On the left, there's two patients with detransition under the relatively certain significant improvement in pressures. On the right, you can see the pressure range before and after increasing diaphragm for the patient with cancer circulation. And one of the bodies of hypertension, prevalence, and how that is a role. That the transplant listing criteria talk about heart transplant patients with congenital heart disease and risk of developing pH in heart transplant. PDR more than 3 or transplant greater than 15 minutes. So implanted monitoring has been helpful in this case, not in this in patients that could improve the challenge after implantation. So systemic systolic dysfunction, hospitalizations, and similar to the functional status. As you can see here, pulmonary hypertension with PA pressures around 50. So he started out to keep loss and had improvement of symptoms. And then hypertension, as you can see, and for almost 2 years, he had symptoms, and his blood pressures were stable. We minimized catheterizations and continued to monitor him. And as his pressures slowly increased, and he decreased, he preferred for transplant listing. And then the last cath is were still reversible. For this patient transducer who has mild pH due to pulmonary venous obstruction with no functional limitations. Again, PA pressure is stable. We monitor with minimized catheterizations. And for those who have pH that was not proper, we have three patients who are like that, as you can see on the left, one with transposition muscular, one technology fellow, and one with joint transposition. And my monitor is helpful here. And we generated diuretics and nitrous before that, and really interventions were not helping. And the pressures were elevated, but did not need repeat catheterizations. Indeed, the monitor used all three patients with echo to estimate speed after placement. You can see that it helps identify improvement in PA pressures and minimize catheterizations into the patient such that we can undergo fluid transplant evaluation when the pH is resolved and both the patient with tetralogy flow and CCGA are now for transplant. And when the pH in the patient with transposition did not improve, and the monitor has been helpful to type of pulmonary ventilators, but repeat caths were still needed on that cycle. So next, I want to go to some outcomes data on monitor use patients with content circulation. We reviewed the cases of 5 patients with cardiac from 2022. And for context, we cared for 198 patients with Fontan circulation. And a patient with Fontan cardiac catheterization was discussed at the plenary conference and discussed the helpful. And as you can see, the 15 patients discussed, 19 were referred to prior placement during their cath. The criteria we use mentioned class 2 or 3 with either prior heart failure hospitalization, overworking functional limitations, or prior function. In the 19 referring, one patient had transfusal and just decided not to place due to the procedure. So 17 patients had successful placement of the device. Age 30, and we had a follow-up for a median of 30 months, 83 months. So you can see here the present heart failure hospitalizations per year to the equivalent placement. With 30 hospitalizations in 10 patients a year for 54, actually, 35 months follow-up in 10 patients. The only group that did have numerically fewer hospitalizations were those with ejection fraction, or those with PLD or ejection fraction or hospitalizations. This last hospitalization needs to be in a little context. First, 2 patients accounted for 32 giving them recall the approval trials, most patients in transmission rate, well, our median was 2.7 heart transmissions per week. So 46% of the heart failure hospital patients had a transmission within a week before, or make medication adjustments if there's no data. And finally, as you all know, heart failure hospitalization is late in the process. Sorry. Slides went crazy. It's late in the process of Fontan failure. Anyway, it's late in the process of Fontan failure. What we're going to show is that in the heart failure hospitalizations that had a pressure monitor beforehand, the median pressure difference was 3 millimeters of mercury higher than their baseline Fontan pressures. And to show how ill this group of patients was, 2 underwent transplant in the time period, and 8 others died. All of them who died had either not interested or declined for transplant. And as you may expect, those patients who died had significantly higher pressures, as represented by the gray lines in this figure. Such that by logistic regression, the implanted monitor pressures for the first 30 days after placement were significantly associated with mortality with an odds ratio of 1.27, whereas the measured Fontan or PA pressures at their last catheterization was not associated with mortality. And 17 millimeters of mercury seemed to be the inflection point for mortality, such that when stratified by this, the implanted pressure monitor readings for the first 30 days after placement, as you can see on the left, there was better survival in those who had with a pressure of less than or equal to 17. On the right, you can see the curve separation was not seen by catheterization pressures. And we don't know the brief mention of liver disease in this cohort. You can see that 10 patients had worsening of their MELD-XI scores during the study's period, with the triangles in the image being the score at monitor placement and the circles at last follow-up. Such that by linear regression, on the left, you can see the MELD-XI score at last follow-up was correlated with the PA pressure by the implanted monitoring pressures. But again, this association was not seen using the most recent catheterization pressures. So this association of mortality of the XI score with implanted monitor pressures and not cath pressures is likely explained by the lack of intrinsic and extrinsic factors which affect the measured Fontan pressure in the cath lab, some of which are not present when the patient lays on the monitor every day to check their pressure. Things like sedation, positive pressure ventilation, fasting status, and inpatient diuresis. Now, a few logistical considerations. For anticoagulation with Fontan patients, when we first started, all patients were placed on systemic anticoagulation indefinitely. And over time, our practices evolved and is patient-specific. If they're taking anticoagulation, then it's continued, but otherwise they take a minimum of 6 months of systemic anticoagulation. And then if they truly do not have other thrombotic risk factors, they're continued on antiplatelet agents. And we encourage those patients with active heart failure or Fontan failure on the left to send transmissions daily. And if needed, diuretics are adjusted with the implanted monitor pressures used as an adjunct to symptoms and weights. And stable patients being monitored for pH they can check weekly or even less often. Our nurses and NPs at Nationwide Children's monitor the majority of the patients, followed by the adult heart failure team at Ohio State. And we review the monitor readings and any treatment plan and discuss them with the patient by phone or chart message. And we're quite thankful for our staff who manage this. And in order to improve the tracking and utility of the pressures the patient sends to the website, we're trying to incorporate them in a flow sheet in the medical record using the pressure, their weights, and renal function and diuretics. So some conclusions in patients with Fontan circulation, similar to those with heart failure and biventricular circulation. Higher PA pressures by the implanted monitors are associated with increased mortality, and the pressures increase before hospitalization. And while I showed some cases where we had successful reduction in heart failure hospitalization, there was no difference overall in our cohort. And then we talked about that implanted monitor pressures may better predict mortality and potentially liver disease than cath pressures. And in patients with biventricular circulation, it can be used to monitor for patients at risk for pH, especially in those where echo is a poor screening tool. It may decrease the need for surveillance caths, and help not to miss the window for heart transplant, and it can be used for post-VAD management in ACHD patients as well. This does give you more questions than answers, though. Some future directions: ideally a trial to see if implanted monitors can help reduce heart failure hospitalizations in ACHD patients would be nice. And given this occurs late in Fontan failure, maybe placing them earlier would be better. Given the association with mortality, could this be used in some sort of Fontan risk score? Do the pressures correlate with liver imaging and biopsy? We haven't looked at that yet. And would early replacement again be beneficial for prognostication so you can see pressure change over time? If there's going to be widespread adoption, we need to decide what the optimal anticoagulation regimen is for patients with Fontan. And with regard to therapies, could medical therapy to reduce implanted monitor pressures improve outcomes? Could this be used to identify patients who would respond to pulmonary vasodilator therapy without repeat caths? And finally, would patient education increase transmissions? Our program has nursing and NP staff who focus on the patients with heart failure, so perhaps utilizing them to contact the patients more often if they're not sending transmissions may be helpful, but we need to make sure there's adequate staff for this. So thank you for your attention. I'd like to thank many people at Ohio State and Nationwide Children for their assistance with this project as well as my education. And I'd like to publicly recognize Dr. Daniels for sharing this Grand Rounds opportunity with me. He's a great mentor and program director when I was a fellow, and this is a prime example of sponsorship in my early career faculty role.
Thank you, Professor Curt and William, for excellent presentation and very interesting data. So if anybody has any questions, please either write them in the chat or just unmute your microphones and you can ask their questions. So while people think about questions, I was writing the questions as you were talking and you were answering them as you were giving your talk. So I were running out of questions. So I guess one question that comes to my head is the funding, right? So we in Canada we don't have funding for CardioMEMS, so it's not funded by the government. So we have CardioMEMS and we have is hospital funded, and we have to justify case by case, which is it's not difficult to get if you have a good reason. And how do you fund the CardioMEMS? I know in the US is funded by the insurance is easy or so the funding for this and the funding for the program to monitor all of those. The amount of people that you need.
Well, we definitely still struggle with insurance and CardioMEMS in the U.S. There are specific guidelines and FDA approval under specific guidance, and we still have insurance companies that will deny it. We have a pretty active set of research and data we send back to the insurance company. That's how it works in the U.S. They deny it, we appeal it, and then for most we've actually been able to get through. As you can see, we've planted quite a few. So it is a process. It doesn't always get cleared through, but it is FDA approved, which is our system of approving devices in the U.S. So we utilize that the same as acquired heart disease, use the same criteria. That's how it's worked for us. And we also use our adult conjunction. We use language that makes sense sometimes to say, gosh, if we can decrease hospitalizations, if we can decrease heart catheterizations, if we can do certain things, it actually would save the insurance company money potentially. And so, we definitely use those things to advocate for our patients. Not that we have all the same data as acquired heart disease, but that's what's shown in acquired heart disease. So we utilize that in the U.S. to try to get these devices approved, and most of the time it's successful.
Mm-hmm. So people are still waiting for questions. I continue while people think of questions. So I have another question that I had is just regarding the fact that CardioMEMS the pH predicts and the MEL score predicts mortality, but not the catheter. I know that you put on a slide there with million other reasons that million reasons that can happen. It's still difficult for me to understand what can be or what do you think. I'm sure that you don't have the answer, but that you have thought about it for sure. What do you think could be the main driver that the fact that somebody has a primary pressure in the catheter today and doesn't predict mortality, and you have the same primary pressure can be just the dynamic of the changes of the pulmonary pressures over time. I don't know. Just
I think I would say, first of all, that was a little bit of a surprise to us. And when we were looking at how the data seemed significant, it was a little bit of a surprise to see how there was a difference between heart cath data and CardioMEMS data. I mean, from a liver disease standpoint, it kind of makes a lot of sense because you're looking at the Fontan pressure over time in the ambulatory setting and not, again, we use the term artificially derived or, in the cath lab, which you're getting under sedation and laying flat and, everything else that goes along with having NPO. And so how is that real life Fontan pressures for many patients as opposed to what we're getting in the ambulatory setting? So, philosophically, it kind of makes sense that you're getting a real life pressure over time as opposed to a single time in the cath lab when conditions we know, can be very different. So I think that is a surprise. I certainly think we need to do more to really tease that out and then really see if that's the case. But our initial data shows that to be true with our Fontan patients. And I think all of us who go to the cath lab and take care of patients, and we know they're so sensitive to preload and afterload and what the numbers come out to be. And trying to calculate numbers and resistances are tricky in that population. So again, it seems philosophically to make sense. Just anything else?
Yeah, I think it's probably the majority of it is related to the sedation, just based on, looking at the patient's systemic blood pressures in these cats are always, they're always, very low, and not very different from their real life pressures. And high NPO status is the other bigger piece of that.
One thing I find very interesting in the Fontan is that when you do in the cath lab, you're measuring patients at rest, and the Fontan, with how the pulmonary pressure change on exercise. I think this is a significant predictor of every single Fontan failure. And we don't have that data, but that would be very interesting. That depending on the type of Fontan, how your pulmonary pressure changes on exercise, or how your pulmonary pressure increases within the Fontan circulation on exercise, might be interesting data to look at. Edwin, you have your hand up, so please go ahead.
Did we?
Sorry,
as I said, we looked at a few patients, in that way, more curious. So, the way CardioMEMS work is there's a pad and a paddle. We can take that paddle, we ACE-strap it onto the patients, put them on a bike, and you can actually see their Fontan pressures in real time as they're exercising, and actually watch. And then we put that in our second paper, just, actually trying it out in 4 patients, and it worked. It showed us their Fontan pressures with exercise in real time, just by putting that paddle on. And so we found that fascinating, as you say. I mean, there's something to that for sure about patients being up and active, and their Fontan pressures are what they are laying flat, whether in the cath lab or just flat on the table. So I am fascinated by that as well. And I think there's a lot more we could do there.
That's a very interesting area to explore that we don't know anything, and a lot of to learn. So, Erwin.
Thank you very much for this very visually talk, and I think this is the largest series of invasive monitoring in congenital heart disease patients in the adult population so far, as to my knowledge. I have a question regarding the complication rate. So, is there any complication, for instance, dislodgement of the device or an infection? So these devices are in place for months, so up to 6 or 7 years in one patient. Are there any serious complications if you need to exchange, replace the device?
I'll start, and then Dr. Marshall can add into. Yes, we've had CardioMEMS for years for many patients, and in general, we have not seen any significant complication. Again, the very first patient we placed it in, the number one concern I had is kind of thrombose. We're putting something in a Fontan circulation, which everybody says you shouldn't do, and is this device going to thrombose in the PA? And of course, we picked patients early on that were already on Coumadin, so we tried to not have early failures. Everybody had to be on Coumadin and stayed on it, and we didn't see any device thrombosis at all. We've never seen an infection with the device. And then once it's really in place, it's going to start to endothelialize in the position. And so it's not going to, it's not something you can take out and remove, at least after it's been in for a little while. And as Dr. Marshall said, we really don't know the anticoagulation strategy. It's really been through taking care of patients, seeing what happens. Our patients don't take Coumadin sometimes, even though they're on it, and their INRs are subtherapeutic, and they didn't thrombose. And so we said, well, maybe we don't need to be on Coumadin for every patient forever and ever. Maybe they can just be on antiplatelet, which is the standard for acquired heart disease. And there's never been really any embolization once it's been placed, except for one in the cath lab, jumped from one side to the other where it was placed, but nothing, post device placement, finding it go out of position, later on, no infections. And we've had one patient with pulmonary embolism that was in the same location as the cardiomems, but the patient also had a hysterectomy. And we thought it might have been an EVT after the travel. She only had a single right or a single left pulmonary artery Fontan, and we actually placed the device in that side. And so probably that was the most likely place for a clot to travel to after her hysterectomy. And so it was immediately after that, a couple weeks after that. So we're not sure if it was related to the device or she had an EVT that traveled. That's the only one that we're told.
Yeah, and specifically, she had been on anticoagulation, but was having this uterine bleeding, and so had the hysterectomy, which was days before actually the PE. And so hard to know which was the cause. And really, the only other the device embolization is well described in the third paper you guys wrote, but is also well described in non-congenital patients as well. And then the only other potential issues have been just access site bleeding, which obviously occurs in patients without with a cath at any time otherwise. So those were the kind of two, the device embolization and the one pulmonary embolism. And then for the clots, there were about half the patients had a contrast enhanced CT or MRI of the chest for some reason or another in follow-up, and none of them showed a subclinical thrombosis or anything like that.
So we have a couple of questions in the chat line. Before we go, I would like to give people the opportunity to show you to answer them. So one is for Marta Ferrero, who is a staff half a cardiologist in Spain. Is currently with us for 2 months, and her questions are so. You show a reduction in pressures after treatment of the single ventricles. Do you have any information on the role of SGLT2? I have to disclose that Marta is SGLT2 inhibitor. So, and the second question that Marta has is something on the line we were discussing already. So if you have any information about the change in the pulmonary pressure with exercise between patients with single ventricle and patients with biventricular circulation systemic heartbeat.
For the second part, the exercise part, no, we don't have a lot of data. We trialed that to see if it would work, and in the future, our plans are to do more with exercise hemodynamics in the population, but we haven't done a lot of it. I'd say the first part was just feasibility, would it work? But if I had to think, forward thinking, this would be a perfect way to look at medical therapies and then how they respond, right? So that's kind of the goal. The goal is to have we have cardiomems placed in almost 40 patients, I think, and to do that with now exercise and medical therapies, I think that's the goal in the future. In terms of SGLT2 inhibitors, it's funny you asked that because I sent a message this week that we have an adult Fontan patient I saw in one of our outreach clinics. He has a cardiomems in. His Fontan pressures have always been low 20s, 22, 23, 24. And despite our best efforts with diuretics and other therapies, we cannot get that down. But this week, we started him on SGLT2 inhibitor. And what we're going to do is he's going to send us a cardiomems pressure tracing every day for the next 2 weeks after we started. And isn't that fascinating? To see, does this actually therapy work in real time in a patient? You couldn't get that with a heart catheterization, right? I mean, because you have to get a baseline, put them on the medicine, and go to the cath lab, and did it really change or not? Here we're going to be able to watch every day with his weight and his heart rate and see. Obviously, concern is if we're going to affect his cardiac output and take too much fluid off of him, or we can watch his heart rate. We can watch his weight and watch his cardiomems now and see, does this therapy actually lower, his Fontan pressures, and everything else is controlled. And this will be fascinating. So it's a great question. And I think that this may be a really important therapy for those patients, actually.
Fantastic. And the last question is that excellent talk that from Dr. Almufla. we learn a lot. So how often do you have to repeat right heart characterization to recalibrate the device? And how do you mitigate the issue of during adherence for transmittance that the patients don't transmit, right? So how do you deal with that? And just another question just that is also in the chat. How do you deal with the device in the patients that you send to transplant? You remove it or not? It's two different questions. Yes.
Yeah. It's stayed in patients who've been transplanted and can actually be used post-transplant sometimes, at least in ICU in the immediate setting. For the recalibration, the data on cardiomems is only for about a month after placement. They showed Swan-Ganz catheter correlation. So ours, we do not routinely recap for unless we have another indication. But there would have to be 7 patients who had a repeat cap with Fontans. But this is almost 42 months out, and 2 of them had the pressures that were exactly the same. 2, the pressure was within 1 or 2 millimeters of mercury, and those were recalibrated just as they were there. And 3 that were a little further out were off a little bit more and were recalibrated. And so really our kind of practice is if we're doing a repeat cap, we recalibrate. If they're listed for transplant, you end up going after collaterals and things like that. So we just recalibrate whenever we do that. And then if the pressures don't match the clinical situation, we'll do it. But otherwise, we have it routinely recapped just to recalibrate.
Yeah, in all honesty, if we get some strange numbers, and they don't kind of make sense with the clinical picture, and so we are, easily taking them back to the lab and see what the numbers look like and recalibrating if everybody agrees that's the right thing to do. So, seeing their clinical picture and seeing the numbers, we can make some of those decisions.
Yeah, although so the Fontan patients, none of them were capped just for recalibration. They all started to correlate. There's one mustard patient who had pressures that were pretty off and required recalibration and was fine after that. And as for the dwindling adherence, it depends on the patient. The interestingly, the patient who we have the longest data on at 83 months or something like that sends a transmission every single day. And then some patients, we have to call them and so it's just kind of patient specific.
So I could continue asking you questions because I find the topic extremely exciting, and the fact that we can have real data to see how to manage these patients is very, very exciting. So looking forward to your reporting the data that you are working on, and thank you very, very much for presenting here today. It's been a real pleasure, and I really enjoyed the talk. And for all of those that have attended, thank you for attending today, and see you in another 2 weeks. And good morning, good afternoon, or good evening, wherever you're in the world. Thank you, Curt, and thank you, William. See you. Bye-bye.